Good afternoon, everyone. It's Patrice Burgess. I've been watching my clock to wait for it to get to noon. Thank you all for joining us, and thank you so much for all of your work between meetings. I know we're asking a lot. I have a lot of information for you all to review, and I know you all are getting feedback just like we all are, and we're doing our very best to keep up. So thank you so much for all of your work. And before we move on to today's busy agenda, I just kind of want to remind all of us of our main goals, which are to advise the governor and also assist the state and local entities with prioritization of vaccines, particularly when they're in limited supply, communication, delivery of the vaccine, and then ensuring equitable access to the vaccine across the state. So those are our overarching goals, and we'll talk some more about some of our guiding principles as we move along. So I'm going to turn over to Elke for the next slide.
Great, and I'm just going to reiterate Patrice's welcome to everyone. Thank you so much for taking the time to spend with us today. We have a very, very action-packed agenda. A lot of interaction with you all, votes that we need to go through, and a lot of detailed information that you'll need to really kind of listen to and absorb. So when we get to the voting part, it will help you be more knowledgeable about your votes. Thanks, Patrice. And I'm going to take the next slide, if we can go to the next one. So today I wanted to give a quick reminder to the group. Patrice already covered this. My apologies, Dr. Burgess already covered this. And but wanted to reiterate the fact that we know that many of you are providers on the phone. You're actively doing work in the field of vaccination, and that we do have provider education webinars that are available. So we have them listed on here, and as well as the web link where you can go and get more information about the webinars. And so we encourage you to do that, because I know there's a lot of operational and sort of logistics types of information that you want to share, or questions that you may have that's not really relevant to this advisory committee, but it would be better suited for these webinars and sort of that tactical approach to giving the vaccine that might be more useful for you. So just want to make you aware of those. Next slide, please. Just as a reminder as well that these meetings are open to the public in a listen-only mode. Public comments, of course, as we say for each of these meetings, will be always accepted in writing. We have a designated email box, as you can see below. It's COVID-19 vaccine public comment at dhw.idaho.gov. So as you can see on the slide, if you can see it, if we get those comments by Monday at noon, we will be able to then bring those comments to CVAC. It takes some time to build these presentations and get everything organized. So when we bring voting and input to CVAC, we have the ability to kind of have a clear designated time where we cut that off so we can build the information to get it out to CVAC. So that's why we have that deadline on there. But we're always taking in comments, but we do have to kind of have a hard stop. Also, I wanted to, as you have probably seen, we do have an ASL interpreter that's providing support for our meetings. And if you notice, the video of the interpreter is pinned up on the top of the screen. So if you need the video larger, click on the layout option in the upper right-hand corner and then click on full screen. And then once the full screen appears, a floating window of the panelists would show, and you can also increase the size of that by dragging that box to expand. So next slide, please.
So the first thing we're going to do before we launch into our presentations and today's votes is review our previous votes that we did electronically between meetings. And just kind of want to also mention that we've been listening to all of your comments and requests, and we know that that's tough to vote between meetings. We really incorporated a lot of that feedback into today so that we can give you some even more information and data to help you with the votes, and we'll try to get through as many as we can in person. but we are on a timeline, and we have to sometimes do votes between meetings, and so we'll try to limit that as much as we can. We've also had requests to meet weekly, but it really does take that full 2 weeks to get all of this information. As you'll see, you're going to get a lot of information today prepared for you, so we're going to have to continue with the every 2 weeks with some communication in between. So let's review what we voted on last time, and we don't want to go backwards unless the only time we're going to go back and revisit is when ASIP or the CDC comes out with a new recommendation. Then we do feel it's appropriate to go back and compare that to what we already voted on, and that's one of the things we'll be doing today. But next slide, I just want to show you what we've already voted on. So everything in the black lettering has already been voted upon. What we voted on between last meeting and this meeting is going to be listed here in red. So as you can see, we added to this group here under outpatient clinical staff the people that are actually administering the vaccines. So that was one of our votes that happened between meetings. Next slide, please. And then the other, these were basically clarification votes to clarify within these categories. So as you can see here, under the outpatient and inpatient medical staff, we included school nurses, the Idaho National Guard medical staff, blood center workers, psychiatric residential treatment facility staff, radiation therapists, and optometrists. Again, really a clarification. And one thing that has come up, there were some people that were thinking the National Guard fell under the federal allocation, but they actually do not. They are under the state, so they don't have access to the federal vaccine. Then the next set of votes down here under public health and emergency management response workers, including the Idaho National Guard that are deployed to support public health response, and state and public health COVID-19 responders that are unable to telework, were two of the clarification votes we agreed upon between meetings. And then the last thing on this slide, under long-term care facility residents, we included residents of long-term care facilities that are within correctional or detention settings, residents that are in certified family homes, and participants in group adult daycare programs. And I want to mention that all of these votes that we took between the meeting have been presented to the governor and approved by the governor. Next slide, please. So I think we're going back to Becky for this one.
Yeah, thank you. So this is, we wanted to make sure that there was a clear understanding of how we're taking this input. As you have heard and you've seen, we've been getting a lot of input through our public portal, through emails, phone calls. A lot of it is clarification. A lot of it is just reinforcement of kind of stating a position that we want to be in a certain category. So this is just to really reinforce that as that input comes into health and welfare, we are screening. This is really in particular around essential workers for the most part, but we are screening those that input through CISA, which is the Cybersecurity and Infrastructure Security Agency. And so that, if you go to that website, it already kind of predetermines who is in what essential worker category. So unless the input that comes in is not listed in there or needs further clarification, we feel that it's already addressed by CISA. So we're only bringing to you the things that are not already classified. And so we're looking at clarifications that don't fall within that, and also any requests for sort of re-ranking are the types of things that we're bringing your way, just so there's some clarity on that. Next slide.
Okay, so before we go into the rest of today's things, we just kind of want to do a quick review of what we've already done. So sometimes, you know, always nice to know that we've accomplished things. So as you can see here, there's a list of all of our previous meetings and the decisions that we've made. So back in November 6th, can't believe we've been at this for 2 months, I guess. We agreed to accept early distribution of vaccine to our existing ultra cold storage facilities. Then on November 20th, we approved the 1A category of healthcare personnel and long-term care facilities. December 4th, we then recommended activating the CDC Pharmacy Long-Term Care Facility Partnership. And also on December 4th, we did some sub-prioritization of Group 2, which we're calling, again, it's a little confusing, but we just went with Group 1, Group 2, whereas ASIP has 1A, 1B, but we'll keep that clarification throughout our presentations, and that would be the essential worker group. Then on December 18th, we did some final sub-prioritization of the healthcare personnel, long-term care facility staff, and residents. And then last meeting on January 4th, we finalized some further clarifications to healthcare personnel. And again, this was based on request and input, just to clarify those groups to make sure people understood who were included, as well as long-term care facility staff and residents, and we're able to get the governor to review and approve all of those decisions. So that's where we have been. And today, where we need to go is ASIP and CDC have made some new revisions, and so we need to look at those and vote on whether we are going to go along with those or make any modifications. And then after that, we have some clarifications within the essential worker category that we would like to get through, similar to the clarifications that we had in the healthcare worker category. So that is kind of our grounding, and I believe from there we're going to go to Monica. Monica, are you there?
I see that Monica is there.
If not, I mean, this is pretty simple to review while she's getting off mute. If you're attending as a designee for an advisory voting member, please make sure and let us know in the chat. We stopped taking full attendance. We're really taking attendance through the chat, so it's helpful for us to know if you're attending in place of someone else. Next slide. Monica, chime in when you're available. This is our overview of the agenda. So we've already done our opening remarks, and we're at this point here. We're reviewing attendance and overviewing the meeting. We're going to have a presentation from Sarah on the vaccine program progress, and then Dr. Hahn will be talking about adverse events and the reporting system. Next slide. Then Dr. Hahn will also be reviewing what I mentioned briefly, the new ASIP recommendations, and giving us information about that. And then Dr. Turner, we have asked, the committee's asked for more detailed information, so we're really excited that she's going to be providing some of this information that you've requested, which basically is within these populations, the rates of illness and death, so that can help you as we prepare to vote. And then we will be going into our voting section, where we'll review the ASIP changes that we talked about and vote on that, talk about timing between the different groups, and then the clarification that I mentioned of essential workers. And then at the end, we will do our typical wrap-up and next steps and look at our next meetings and that type of thing. So I think with that, a few reminders. Hopefully you guys are all pretty familiar with this by now, but we like to have the video on so we can see each other and get to know each other remotely as much as possible. Hopefully you know where your mute and unmute button are, and your hands up button when you want to speak. The chat's also great. We have people monitoring the chat so that the people speaking, they'll let us know and summarize things from the chat. And when we get to our voting, this little button that's being highlighted here, that is, for me, at the bottom of my attendee list and right above the chat, right next to my little raised hand, is a little megaphone. And when you click on that, there's some yes, no options there. We also will be having some polling voting today, where you'll be having some choice between more than just a yes, no. So we'll go over that again, but it should be, everybody should be pretty familiar with this by now. And I think from that, we will be going to Sarah.
Great job, Dr. Burgess.
Thank you so much, Elke and Dr. Burgess, and thanks to all of the CVAC members for all of your time and especially the energy it takes to make all these decisions. as I can speak on behalf of all of the staff at the immunization program, we are really grateful for everything you are doing to help us with this vaccination effort. Okay, next slide. So today I'm going to be talking a lot about logistics and how the doses are coming into Idaho and the cadence that we have right now, and the cadence that we can expect moving forward. And because that really kind of feeds into, that information feeds into a lot of what you will be, helps feed into what you'll be deciding throughout the next 2 hours. So next slide, please. So this slide really goes through how the doses have come into Idaho for the state allocation. So just to review, we had 13,650 doses of the Pfizer BioNTech vaccine that very first week, right after the Pfizer was issued an emergency use authorization. Immediately after that week, over the weekend, the Moderna vaccine was approved for emergency use and was in Idaho the very following week, the week of December 21st. So we then had 1,950 doses of Pfizer BioNTech vaccine and 28,000 doses allocated to Idaho for the Moderna dose, for the Moderna vaccine. And as you recall, we had asked you in mid-December to guide us on when to activate the pharmacy partnership program. So we activated that program as for week 2, which was at your recommendation and the governor's approval. And so doses from our state allocation.
Monica can't get in either. She's our
doses from our state allocation beginning the week of December 21st were transferred over. And in that time, the pharmacy partnership program for long-term care, that's what the doses were transferred to. We also learned that the required amount of doses, we couldn't meet that, but CDC changed the allocation. So what we were going to have transferred over to CVS and Walgreens over 3 weeks then became 4 weeks. And so there was a cadence planned for the week of December 21st, December 28th, this week, January 4th, and then next week for 7,800 doses of Pfizer. And if you recall, we were selecting one vaccine presentation for that program, and we chose Pfizer. 7,800 doses were being transferred over. So this slide shows what was available as of this week and allocated to Idaho. So we have, as of this week, we have 67,875 doses available in Idaho. And just for your awareness, there were, during the week, last week, we had the CVS let Walgreens know, let CDC know that there were some facilities in Idaho that they realized they could not contractually meet their obligation to provide the vaccine at those facilities. And so Walgreens was able to pick up the slack and take on those facilities. But what that required, and then there were some additional facilities that wanted to enroll in the program after the deadline. And that was okay with CDC if it was okay with the pharmacies and us. And so everyone was okay with that. And what that meant was Walgreens took those additional late enrollees of long-term care facilities into the program, but they needed additional doses from us. So during the week of December 28th, sorry, this week, there were no Pfizer doses available for the state allocation because we allowed Walgreens we transferred all of our allocated doses of Pfizer to Walgreens so that they could vaccinate long-term care facilities. Next slide, please. So here is the schedule of dose transfers to the long-term care pharmacy partnership program. The 7,800 each week, but this week we had 9,750 doses available or transferred over to them. So that is a total of 33,150 doses that are part of the state's allocation that Walgreens and CVS are using to vaccinate long-term care residents and staff. That is not all of the long-term care residents and staff. There are some that did not opt into the program, and those doses are in the state's allocation, and those doses are being allocated to the either health district or local provider that the facility chose. But for the pharmacy partnership program, it's 33,150 doses, and that includes a transfer of next week's allocation. So next slide, please. I also want you to see the cadence of delivery. So every week we are working with an allocation for the following week, and then also our providers are getting the doses delivered from the previous week that we were allocated. And so if you look at this calendar, you can see how things happened over the past month. So beginning on December 14th, and then on the 15th and the 17th, those 13,650 doses were shipped and delivered to Idaho. And those were the first dose. And in this calendar, you see primary and booster dose. And really what that is dose 1 and dose 2 of the series that are required for both Pfizer and Moderna. And in the second week, you see that Moderna comes in to play, and we had, if you remember from my other slide, we had 28,000 doses allocated. What we ended up doing were ordered and shipped 26,900 doses, and then the remaining doses were delivered on the 29th, and that's why we have less Moderna than were allocated the week of the 20th, but more Moderna shipped than were allocated the week of the 28th. So in that far right column, you see the totals that are delivered in Idaho. And then starting January 3rd, you see in that second row.
Kelly, I can.
You can see the booster dose 2 in the series coming into play. So as you look at that on January 4th, 13,650 doses of the Pfizer BioNTech, that's dose 2. So all of those people who got vaccinated with the first 13,650 during the week of the 14th, all of those doses are really kind of reserved for all of those folks. And then in that top row of January 3rd, the week of January 3rd, you see the Moderna, and Moderna is the 9,700 doses that we have. And so at the bottom of that slide and all the words that you see, that's sort of our pace every week. So Tuesday, we have an anticipated allocation in Tiberius, which is our planning tool. This is where we get the numbers from Operation Warp Speed. Wednesday, Operation Warp Speed validates those allocations, and the number becomes more or less confirmed. And then at the immunization program, we look at the population or subgroup we need to vaccinate. And so right now it's been phase, all those populations within phase 1A and the subgroups and the numbers that we have to vaccinate. And we try to distribute those doses based on the percentage of that subgroup within each health district. And then we let our health district partners know, and then they have a few days to come back to us with where they want those doses to be ordered and shipped to, distributed. And so Thursday through Sunday, there's the planning of distribution by our local public health districts, and they let us know what they want, and we place the orders. And then Monday through Thursday of the following week, those doses are delivered to Idaho. Next slide, please. So right now, we have been told for the past few weeks that the expected allocation moving forward is this same cadence of 9,750 doses of Moderna weekly and 9,700 doses of Moderna weekly and 9,750 of Pfizer BioNTech. So that's a total of 19,450 primary doses weekly. And the reason why I am talking mostly about primary doses is because that's really the number of people we have. We have doses for people, and we really, from our planning perspective, aren't looking at those dose 2 shipments because those are really already accounted for by a person. And so the reserved second doses also arrive in the cadence, and as you saw on the calendar that I had on the previous slide. And all the doses may be pushed out together so that, the obligation right now is not on our providers to hold back doses for the booster dose or the second dose in the series. Next slide. Oh, I thought I had one more slide in there. I do want to say one more thing about this is that if you're catching up on headlines just from this morning, Washington or the Wall Street Journal and other news sources have announced that the Biden administration have announced that they plan to release all doses and not hold back those second doses. So by the next time we meet, I might be presenting a whole different logistics plan for this. So I think it's a stay tuned, but right now all we have, what we have to work with is the plan of the 19,450 doses. And so that's how we work with our local public health districts and that's how they're working with their providers in their district. So I am open for questions now.
And Sarah, this is Elke. You do have some questions in the chat.
Yeah, Elke, I was going to put those to Sarah.
Got it.
Sarah, basically, some of our participants would need a summary. How many doses has Idaho received? I mean, your doses were split across 2 slides. Can you provide just a summary of what has been received in Idaho?
For pharmacy partnership and?
Total.
Okay, let me just do a quick addition. It should be, about 100. Need time for my slides to catch up. Sorry. Of course, when I'm using my calculator fast, I make more errors.
Well, Sarah, while you're doing that, another question was about the how many we've received versus how many we are displaying that we've administered on the coronavirus.idaho.gov page, which is 20,194 as of today. So once you have that calculation, could you also talk a little bit about the difference between what we've received in Idaho versus what's been administered?
Yeah, so the calculation right now, as of between pharmacy partnership and what's in Idaho this week, we have 101,025 doses. And just as the last 7,800 of those doses have been transferred to Walgreens out of next week's allocation. So that's, but anyway, yeah, it's just about 101,000. So to the point about the difference between this number and what is showing up as recorded in the Idaho's immunization information system, there are several. I guess the question is why, right? And there's several explanations in that. First, a lot of these doses are arriving late in the week, and so providers are really catching up, at the end of the week, unpacking them, storing, ensuring the proper storage of them, and then planning their clinics. And so now that we have a regular cadence, also the ordering was a little different over the holidays. And so now that we have a regular cadence, we hopefully, we know now they can plan for the doses that they're getting. We anticipate that will change, that pace will get better and faster because they know what they can plan for and they can start to plan more clinics. Prior to I'd say late last week, it was a little bit staggered when we were getting the information and also the numbers. So as you remember, a couple weeks ago, maybe it's been a month. We thought we had 19,000 doses and it went down to 9,000, or it was there was a 40% difference in that. That affected our pharmacy partnership program activation. So there's several variables that are playing into that. We also we know that in some areas there's some vaccine available, and that healthcare providers, the vaccinators, are saying that they've kind of run through all the healthcare providers who want the vaccine and they're now wanting to move to the next phase. So there's several things going on.
So this is Monica. My apologies, everyone, that my internet went down seconds before it was my turn to speak. So apologies for that. But I just wanted to mention we have about 3 minutes left for further questions and comments right now. Please put any additional comments and questions in the chat so we can capture those and address them the best we can. Our subject matter experts monitoring the chat might be able to do some of that for us as well. So we have a couple more minutes left. I don't see any hands up. Is there anything in the chat that that we're seeing that would be a good question right now?
Thanks, Monica. I think right now, I think we will get to some of these questions that are in the chat a little bit later on in the meeting, and we'll answer some directly in the chat box.
Excellent. Thank you so much. All right. With that, Sarah, is there anything else you'd like to close with before we move to our next presentation?
No, I just want to reiterate my gratitude to the committee members.
Excellent. Well, thank you. And thank you for doing those quick calculations on the fly today. No pressure, right? In the middle of a meeting. Excellent. Thank you. All right,
Sure.
Everyone, for the sake of time, and I am so sorry I couldn't do all the overview pieces that I wanted to do with you, but I'm sure you heard this from Dr. Burgess because I heard she took over for me. Thank you. We have to keep very strict on time today, even more than usual because we have so much to cover. So I will be helping keep timing as well, letting folks know if we're getting close to the end of presentation times and so forth. So thank you for your help with that. And again, use the chat, please, as much as possible to make sure we capture anything we don't have time to talk about live. All right, with that, I'd like to turn it over to Dr. Hahn to talk to us about vaccine adverse event reporting in Idaho.
Thank you, Monica. Can you hear me okay?
I can, which I'm hoping we all can.
Yes, thank you. For those of you that cruise the participant list, I couldn't get in this morning. My computer is not being nice, so I'm on Angela Wickham's computer. So just to avoid confusion. For this piece, I'm just going to talk a little about adverse events reporting in Idaho, of course, with a brand new vaccine or vaccines that are both under emergency use authorization. We want to make sure that we let you all know quickly about what we are doing. Next slide. So as most of you are aware, there are 2 vaccines now that are authorized to be used in the United States. FDA is the one that authorizes the vaccines, and then ASIP and CDC make the initial recommendations on their use. But I put this slide up partly to remind you all that we've got others in the wings, and we may eventually have 3 or more additional vaccines available for use in the United States. So this is going to be an ever-growing challenge in trying to make sure that we are monitoring for safety as these vaccines get rolled out. Next slide. So this is a CDC slide. You can see the source below that was recently presented at an advisory meeting of CDC, and you can see here the top 2 are the ones that the top 1 is what most of us are familiar with. It's called the Vaccine Adverse Events Reporting System. It's monitored and managed by CDC and FDA together, and this is what's used if you or I get a bad reaction to a flu shot or a measles shot. This is where it all goes to, and this will be used, of course, for COVID and is being used. In addition, a new tool, vSafe, managed by CDC, is being offered or should be offered to all recipients of the COVID-19 vaccine. Recipients are given a flyer that says they can sign up for this. It's voluntary, it's secure, HIPAA secure and compliant, and they can report every day for the first 7 days, and I think it's a couple times a week after that for 5 weeks, how they're feeling, any side effects, any problems, and if anybody reports anything serious, CDC is following up with phone calls. In addition, you can see below, I won't run through them, but there are other monitoring systems for safety in place for special populations like Medicare patients, VA patients, military, folks in long-term care, et cetera. But I wanted to highlight the top 2 because those are what we're already getting information from. Next slide. So this is just a little more info. Again, most of you are familiar with VAERS, but the reason I wanted to put these up there is to highlight that these are reports. Healthcare providers who are administering COVID vaccine are required to report adverse events of moderate or severe intensity, if you will. So a minor sore arm does not need to be reported, but anything considered moderate or severe does need to be reported into VAERS. But in addition, people getting vaccine can also report directly into VAERS. And in addition, as I already mentioned on the right, they are offered this smartphone type tool where they can report themselves directly. So we should have some, and we are starting to get incredibly rich data from people who've received the vaccine on how they're doing. Next slide. And I want to assure you that this information is being turned around quickly and being reported back out to medical providers and the public. You can see here 2 updates from just Wednesday. On the left, you can see an MMWR published about initial safety data from the Pfizer vaccine. We don't have time to go through it, but you will see, this is of course publicly available, and you can see that there is concern about some people getting allergic reactions, including anaphylaxis. Still very rare. The very first report, which covers the short time span, is estimating maybe 11 such events per million doses, which is higher than we see in other vaccines. So this is going to be closely watched. And you'll see to the right, this then translates into clinical considerations for use of these vaccines, including some cautions about people who've had a prior history of any sort of allergic reaction to an injected or medication or vaccine. And that was just updated January 6th as well. Next slide. So in Idaho, we are also working with the federal partners to make sure that we are hearing about reports into VAERS. We also have many Idaho participants we know participating in VSafe. And if they are reporting adverse events, that will go into VAERS. Well, in addition, to CDC, I should say, has received them into the VAERS system. Caution about people. Both of these folks had prior severe allergic reactions to injectable medications or vaccines. So it was a reminder and actually a strengthening of that language to defer vaccination and consider deferring vaccination. I guess the provider and the patient can certainly make their own choice. Now we have more information today because of the MMWR about the risk, the real level of risk in this population. But we wanted to make sure we let the public know and providers know as quickly as possible about the concerns. And we will continue to do that work throughout the whole campaign. And I think that's my last slide.
Yes, it is, I believe.
Okay. Thank you.
Thank you so much, Dr. Hahn. We are right on time here, and this was meant to be a quick update for you. Please, again, if you have any questions or concerns, put them into the chat, and we'll keep an eye on that and bring things forth as we need to. But in the interest of time, we're going to move on to Dr. Hahn's next presentation with regard to ASIP recommendations, an update. Dr. Hahn?
I'm so sorry. Did you have I was looking through the chat in case there were any questions for me. Did you have a question for me?
Sorry about that. We are ready for your next presentation on the ASIP.
Oh, thank you.
Update.
I need to stay with the program. Thank you. Thank you. And I'm sorry about that. Here I am still looking at the old presentation. Okay, thank you so much. And at this part of the presentation, then I'm going to talk quickly about the Advisory Committee on Immunization Practices. Many of you are familiar with, and they made some new recommendations in late December that I want to make sure we were aware of as we started to have our discussions. Next slide. So a reminder, the ASIP is the group that makes recommendations to CDC on immunizations in the U.S. civilian population. And then CDC reviews their recommendations. Of course, they're there as part of the meetings, but then they decide and officially adopt those ASIP recommendations and publish them in the MMWR. It is very rare for CDC to not accept or adopt the ASIP recommendations, but it has occurred, and they can do it, but it's just a rare event. States, similarly, we can follow those ASIP CDC recommendations, including sub-prioritizing the ASIP CDC groups, as we have done already with a healthcare worker group, or we can implement our own prioritization groups. So far, we have leaned towards following as much as possible the ASIP CDC recommendations, as they are based on lots of discussion and input from many stakeholders, a lot of thoughtful review and lengthy discussions about it. Nonetheless, I would make it clear that states are not legally required to follow that. Similarly, CVAC, your group, this group provides recommendations to the governor and about who we think should be next as far as vaccination and other issues that Dr. Burgess already reviewed with you, some of the other recommendations you've made. Ultimately, the governor does have the decision-making authority over the direction of the program, but I know the governor values very much the input from CVAC and is eager to hear what this group comes up with. Next slide. So ASIP has published 4 sets of recommendations on COVID-19 vaccine. starting in early December. They made their initial recommendations for healthcare providers and long-term care residents. They had 2 meetings in which they discussed the 2 vaccines as they became authorized and created recommendations for those. And then December 22nd, it was published December 22nd. Those recommendations were looking forward to phase 1B and 1C, and that's what we want to talk about today in the next few slides. Next. So to the left, I want to show you or remind you, this is where it looked like ASIP was heading back in late November. This is a slide from a talk that they presented where they said, okay, phase 1A, as we've all agreed on, are going to be healthcare providers and long-term care facility residents. For phase 1B, though, after a lot of deliberations, considering a lot of factors that I know you all think about as well, including keeping infrastructure for the economy, keeping grocery stores open, people that are at high risk of being exposed. After a lot of discussion, they voted to have essential workers be phase 1B. And then phase 1C, the third group, would include adults with high risk medical conditions and adults over 65. That was never voted on, though, by ASIP, that proposal. That was just a discussion point, and it seemed at the time, I was in that meeting, a lot of agreement, and it seemed like consensus was building in that direction. However, December 20th, that was the date of the meeting, the proposal and the vote fell out differently. And you can see there, I put in yellow what's different from what we thought was going to happen. So instead of 1B just being essential workers, now it became frontline. And I have another slide showing you how CDC is defining. Okay, could you flip back? Sorry, I'll talk about that in just a second. But I do have you now. You can have seen quickly that slide. Also, though, adults 75 and older were added to phase 1B. And then lastly, now phase 1C became the rest of the essential worker group. So those not considered frontline. Adults 65 and older, so 65 to 74 would now be added in, and then persons with high risk medical conditions, basically under 65. And you'll see there that says 16 to 64 as a reminder that the Pfizer vaccine is licensed for 16 and 17-year-olds. That's why it says 16, not 18, as you might expect. Okay, next slide. Sorry. So here's the slide that CDC showed at the meeting. This is their I would say very high level definition of who they're considering frontline essential workers. And it's really based on risk of exposure. So these are people we all have, that I should say have been decided to be critical infrastructure workers, but those that have to be around other people, that firefighters, police, the people that cannot telecommute, that need to be there, teachers, corrections workers. And you'll see there on the right, these are people that are essential, but may not require so much public interaction. And I think that's my last slide.
Yes, it is.
Okay, thank you. Thank you. So I just wanted, this is just setting the background for our discussion today. I don't know if there are any questions about this, but that's why ASIP did change things around, which is one reason why we're bringing back to you the discussion about the 1B group. Because there have been changes at the national level.
Thank you, Dr. Hahn. We have about 2 minutes for questions right now. So I'm going to check in with the folks monitoring the chat. Are you seeing anything there that we won't be covering later on in the meeting that we could bring forward now?
Yeah, thanks, Monica. We have nothing in the chat right now.
Okay, excellent. Thank you. And I see a hands up from Lupe Whistle. Please go ahead. Please unmute.
Hi. Now, I was looking at the, the 65 plus, and should we be considering, can you hear me okay?
It's a little choppy. Can you repeat your question, please?
Yes, 65 plus, should they be higher on the priority list, especially when the 60 and older? I mean, you're looking at over 90% of the deaths are among that age group.
Yeah, Lupe, this is Chris Hahn. I'll take a first stab at that. We're going to hear a lot about that from Dr. Turner. So I would propose that we defer that because she's really going to be digging into that age, the age groups and the different risks at different age groups. But thank you for bringing up that point. That's absolutely a key part of our discussion today.
Thank you.
Excellent. Thank you for that. Do we have anything else in the chat? We have about 30 seconds.
I just see the question about, do we have an estimation of numbers of individuals in these categories? And yes, you'll see later on, we do have some numbers because they're key, obviously, to deciding prioritization. So they are on our future slides.
Excellent, thank you. With that, I think we're going to turn us over to that next presentation then. Again, for the sake of time, we're doing well. I'm going to ask Dr. Turner to bring up a presentation with regard to COVID-19 population subgroup risk epidemiology. There's going to be a lot of data here, folks, so please be ready to absorb a lot of good information.
Yeah, thanks, Monica. Happy Friday, everyone. Next slide, please. So as Dr. Burgess mentioned a little bit earlier in the meeting, we've received some requests to review the epidemiology of COVID-19 in order to assist you with the recommendations that you're being asked to make to the governor. And so to that end, we're going to spend roughly 15 minutes, which I will tell you is not very much time. So it's going to be rapid fire. Hopefully we don't have any post-lunch tiredness among this group. But we're going to do a quick review of the surveillance and study data about SARS-CoV-2 infections in Idaho, as well as the US. We'll take about 5 minutes on each of these three kind of big areas: disease burden by age, exposure risk, specifically risk to US workers, and the impact of current health status on disease outcomes. And we could easily spend an hour on each of these areas, but this will just give you a general picture. And I want to state really clearly before we jump in that there's a lot of factors about the virus, the populations and the environment that can confound the analysis of those very discrete topic areas.